Get started again, but before we start, I should warn you that my accent isn't nearly as charming or elegant as that of Abby Gewirtz. I find that coming from Milwaukee, Wisconsin hasn't helped me much in the cool accent department, but I'm going to present this case anyway. My name is David Hong. I'm a child psychologist at Washburn Center for Children. And when I came on board about 2 years ago, the timing was very fortunate for me because that was when we were starting our partnership between Washburn and several other agencies, along with Abby's Minnesota Child Response Center. So I was able to get a lot of great training and work toward the goal of implementing and disseminating evidence-based treatments for victims of trauma. My first day of work, I actually got on a plane and flew out to Pittsburgh, where we trained with the developers of trauma-focused cognitive behavioral therapy, which is the intervention that I'm going to talk about today. So I've had the opportunity to meet wonderful clients at two sites. One was at Perspectives Family Center, which is a supportive housing site in St. Louis Park, and the other is our South Minneapolis office for Washburn through our outpatient program. One of the wonderful clients, I'd like to share with you his story. I've changed his identifying information and given him the most common name in the world, actually, which is Mohamed. Mohamed is an 11-year-old Somali boy, and he was born in a refugee camp in Ethiopia. Later immigrated to Kenya for 2 years, then immigrated to the United States at age 4. Currently, he lives in two different households. One is with his grandmother and an aunt, both from Somalia, and another household is with a different aunt and an uncle. The aunt is Somali and his uncle is Caucasian. And the second household those are the guardians that I have been working with most closely in the therapy. He doesn't have siblings living with him. So the reason he was referred was there were several traumatic incidents that happened to Mohamed. At age 3, Mohamed witnessed the killing of his infant brother and the rapes of his mother and grandmother. This would happen in Kenya, where Kenyan soldiers would target refugee populations, follow them to their homes, and try to steal or get money from them. And if they didn't have anything to give them, then they would perpetrate these horrible crimes. From age 4 to present, another traumatic issue for Mohamed is that he was separated from his mother due to a restriction in immigration. Basically, she missed a critical window, and they were letting through children and elderly. They were giving them priority. So he was separated from her. Another traumatic issue for Mohamed is that from birth to present, really, he's experienced abandonment by his biological father, who actually lives locally here but doesn't really have contact with them and has had another family. What the circumstances were was that father was a young teen when Mohamed was born. So he wasn't able to provide or have that father-son bond with him ever in his life. And if that weren't enough, at age 8, he underwent a single incident of sexual abuse by a teenage boy in an apartment. It was a single incident, and it wasn't revealed until much later, so the identity of the perpetrator wasn't ever known. I'm going to summarize the way that he presented just to say that he did meet criteria for post-traumatic stress disorder, and he had both high externalizing symptoms, which were the irritability, aggression, and starting fights with peers, as well as internalizing symptoms, which were the anxiety, the avoidance, the withdrawal, and just feelings of detachment. Mohamed also brought with him to therapy a number of wonderful strengths. He's a very intelligent, very insightful, self-reflective kid. And a lot of what we do in any sort of CBT intervention is thinking about thinking. So we look, it really helps to be able to look at the way or the process in which you think. And he was able to do this quite naturally, which was just wonderful for this particular intervention. He was quite verbal as well. Mohamed was very creative. He likes to draw quite a bit, and in particular likes to draw Japanese anime type characters. And we used his creativity later on in therapy as a nice medium for him to express himself. And finally, he has a very supportive family. His aunt and uncle came with very good parenting skills to start with, which was very nice. Parenting is a component of this therapy, and we were able to use their skills all the way through the course of therapy. So, some basic things about trauma-focused cognitive behavioral therapy. It's a 12 to 16-week intervention typically. It can go longer if need be. Parents are highly encouraged to be involved, or a significant guardian. If it's not possible to have a parent or guardian involved, research has shown that it's still better to treat the child versus having no treatment at all, but it certainly enhances the outcomes to have a good, solid guardian or parent. It's quite directive, and it's components-based. So we go through a number of skills to help children cope with their trauma symptoms, and then get into an exposure piece, which I'll talk about later. Like Abby said, we do a lot of outcome assessments before, after, and during treatment. And also I just want to say that as a model of treatment, it's within the structure of the overall structure, it can be flexible and can be tailored to fit an individual child's needs. So we started out with Mohamed with psychoeducation, and basically this is just teaching him and his guardians what are the normal reactions to trauma. We use a lot of books and pamphlets. Pretty standard procedures for psychoeducation. Parenting is an essential component, and if parents don't have good parenting skills or high-functioning parenting skills, we will help them in the use of things like timeout, positive reinforcement, interventions like that. But all the way through, we do have parents reinforce each component with the child so that they can generalize what they're learning outside the therapy office. So the next component is relaxation. And here what we're trying to do is help give the child a coping skill to handle the physiological symptoms of anxiety. A very standard one is breathing, abdominal breathing. I was trying that right before I got on the mic. It works pretty well. I'd encourage you to take 5 deep breaths, expand your belly, and it's amazing. Let's see. So this can be used all the way through the rest of treatment. Once they learn a skill, we encourage them to apply it as we're going forward with each component. Another component is affective expression and modulation. And this is basically teaching a child what feelings are, giving them names, helping them understand that feelings can be experienced at different degrees of severity. So a thermometer is the analogy that I used with Mohamed. And you can set it from 0 to 10 or 0 to 100 and talk about how intense your anger was that day when you slugged that kid, or how intense your sadness was on a particular day. We also want to teach kids that feelings can be mixed, that you can have several feelings at the same time, and that's okay. A very essential component to TFCBT is cognitive coping and processing. And basically the idea here is that feelings our thoughts are connected to feelings, and feelings are connected to behaviors. So they form a triangle, which is interrelated, and that the most effective way, the easiest way to intervene, if you want to change a negative behavior or a negative feeling, is through the thought stage. Behind most negative feelings or behaviors, there's a negative thought. And I'm going to give you some examples of this. Let's see. We look for cognitive errors that kids make. For Mohamed, one of his was, if it's not perfect, why do it? So this is an example of black and white thinking. And it came out when he was making a drawing, and he would start over and over and over again, going through several sheets of paper. And what we did was we actually used the metaphor of using pastels, black and white, and colored different grades of grayness in between the black and white, and talked about how there's many degrees of two opposites. And he was able to work with this and then go through the triangle to help him apply this to other areas where he used his kind of all or nothing thinking. Another example is it's often easier for children to identify or work with the cognitive errors in other children versus their own cognitive errors. And so we would give some examples of this girl who comes from the manual of TFCBT. Yes or no Yasmin, who was an all or nothing thinker, and she thought, if the world isn't safe all the time, or if the world was unsafe one time, then it's unsafe all the time. And then I would turn to Mohamed and say, well, what's going on with yes or no Yasmin? And he could identify then what were the cognitive errors that she was making, and what would be more helpful or more accurate thoughts that she could use in her assessment of the world. Another cognitive error that he would make is he would attribute it's my fault. Basically, with his father, he blamed himself that he was felt rejected by him. And what we did was we went through a line of processing in which we looked at that belief, talked about why are other reasons, alternative reasons that his father may have not been able to be there for him, and talked about the situations like, is it your fault that your father was a young teenager when he was born? Well, no. And then another line of questioning was, is it your fault that there was a war going on and there was a lot of chaos at the time? Well, no. And so eventually getting to the point where you can replace the unhelpful or inaccurate thoughts with more accurate thoughts. After these skills have been worked with and mastered by the child, then they're ready to go on to the trauma narrative. And the basic purpose of the trauma narrative is to desensitize the child to the trauma. Since the trauma happened in general, this memory has been a tremendous burden to them, and has weighed very heavily on their consciousness. It's been controlling and starting a lot of dysregulation, negative thoughts, negative feelings, negative behaviors, and has really just taken control of their life. And so what we want to do is give that control back to the child with these skills and with this exposure. And we use the medium of story for this. So one thing that we want to do, that I did constantly with Mohamed, is that I wanted to remind him and his guardians of the rationale for exposure, because it doesn't make a lot of sense to anyone to get picked up from school, drive across town in rush hour traffic for several weeks to go talk about the worst things that ever happened to you. And so I would use the analogy of a scary movie often for Mohamed and his guardians. If most kids that I have seen the movie Chucky, and I talked about that scene when Chucky jumps out of the closet, and how did you feel the first time you saw that? Well, I felt really scared. It was freaky. And then go through more questioning. Well, what if you saw that again? You think you'd feel as scared? Well, not so much. What if you saw that 5 times? How scared would you feel? And it would go down and down and down. And that's the rationale It makes sense to kids, although Chucky still freaks me out. So yeah, as we're going through this exposure, there is kind of a sweet spot that we want to maintain for the child in terms of their level of anxiety. If you underexpose a child to anxiety, they're not confronting the issues enough. They're not being challenged by them, and the memories will remain to have a very powerful effect on their thoughts, feelings, and behaviors. But if you overexpose them, you certainly run the risk of re-traumatizing them. And so you want to keep the exposure or their level of anxiety in the middle. And it feels, as a therapist, feels like I've got my hand on a dial and that I'm watching very closely to cues and encouraging the child to communicate what it is they're feeling all the way through. Once we've finished writing down the narrative, what we do is reprocess the narrative and look for any further unhelpful thoughts that have maybe originated during traumatic episodes. And then once they're identified, you can challenge them again, find more helpful or accurate thoughts, and clarify things. One of the final stages of therapy is that this is a key component for the parents to be available, is that the guardians will listen to the narrative, a presentation of the narrative by the child. And before we do this, we want to assess readiness of the parents, because they can often be traumatized themselves secondarily to hear this. And so we never want to have a situation where the child was able to handle the narrative, but looks over to the parent, and the parent is obviously anxious. So we might need to do some parallel desensitization with parents along the way. Once they are ready, we also coach them in praise just to reinforce the fact that the children are confronting these difficult memories. And I might have silent cues like a second base or first base coach would do, like when I do this, say, good job, you're very brave. After we've done this, then there's an opportunity for both children and parents to clarify any lingering questions that they have about what happened in the traumatic incidents. So often these questions get buried very, very deep because these are the incidents that no one wants to talk about. And so there is an opportunity for them to clarify things. Finally, we do a stage in which we help the child understand that they can take measures into their own hands for keeping themselves safe. And this is basic safety planning, identifying 3 people that you would talk to if anyone ever tried to hurt you or hurt you. How to call 911, things like that. And finally, we celebrate with a graduation. And all the way, we're reminding them that there's an end to this. There's an objective here. And once you're through it, once you've reached your goals, we can celebrate this. You can move on with your life, and these memories don't have to have as much power as they had before. So that is my presentation, and I think Abby's going to go back on, and then we're going to have some time for Q&A. Thanks for your attention.